All right, folks, we're here at the top of the hour, and I want to be mindful of everyone's evening for joining us. My name is Steve Roach. I work with the Emory Alumni Association's Regional Engagement and Volunteer Management team. And I'd like to just briefly introduce tonight's session on translating health inequities into legislative action. Throughout the course of this evening, we'll have an opportunity to talk with subject matter experts. But before we get started, I'd like to introduce our two co-hosts for this evening. So I'll turn it over to Christopher DeVore with the Rollins DC Network to talk a little bit more about tonight's session and introduce our panelists.
Hi, thanks, Steve. Hi everyone. My name is Christopher DeVore, class of 2018 from Rollins School of Public Health. I'm also currently a legislative assistant in Washington, D.C. for Congressman Sablon, representing the Mariana.
Wait, why did I say what? Just because it's always avoided. Like, it's always, oops.
We have everyone mute their microphones. That would be great. Thank you so much. And so I work in Congressman Sablon's representing the Northern Mariana Islands in his office on health equity issues, which is especially important for tonight's topic. And over to you, Layla.
Hi, good evening, everyone. I'm Layla Bukhari, and I'm currently the CEBA DC president. And I graduated from Emory University undergrad in 2005, and then went along and got my Master of Public Health from Rollins School of Public Health in 2006 in Health Policy and Management. And currently I work at AstraZeneca, where I'm a global study manager, managing, operating, and running cancer clinical trials. So I'm happy to be a part of this discussion and this panel for today. And we do thank you for your time and thank you for attending. And as far as the agenda, I'll run down it really quickly. We'll have the welcome remarks. We'll have the introduction of the panelists, a moderated discussion with a couple questions to our panelists. And then from there, we'll break out into small group discussions in breakout rooms, and you'll automatically be assigned to a breakout room, so you don't have to worry about anything. It'll be automatically allocated for you. And we want that to be a very intimate discussion where you could ask questions, use the chat feature. Please, be very interactive and ask a lot of questions. And then from there, we'll reconvene and have a last session of question and answer. And then Steve and Laura will give the closing remarks. And so I just want to quickly run through some housekeeping items specifically for Zoom meeting. Please mute your microphones if you're not speaking. You can see here that you could just select mute on the button if you need to. And then also please remember, if you're, we want to encourage personal interaction. So if you could start your video, if you could use your video when you're speaking or in the breakout rooms, that would be great. We want to encourage personal connection. So please, we encourage the usage of that. And then also please use the chat feature in Zoom. If you have any questions, we'll be having moderators watch over that, and we'll be using that to facilitate questions and discussion. So please feel free to use that. And then if any questions aren't answered, we'll answer those at the end of the program. And I'll hand it back over to Chris to start our panelist introductions.
Sure. Thank you, Layla. So our first panelist tonight is Tammy Boyd, class of 97 from the School of Public Health. She's currently the Chief Policy Officer and Counsel and for Government Affairs for the Black Women's Health Imperative. Our next panelist would be Dr. J.W.C. Jones. She's the Chief at the Grady General Internal Medicine, at Grady General Hospital in Internal Medicine. She's also the Vice Chair for Diversity, Equity, Inclusion at the Department of Medicine, and the Dean and Assistant Dean at the Emory Graduate Faculty Development at the Emory School of Medicine.
And our third and final guest is Giovanni Spinner, who graduated from Rollins School of Public Health in 2007. And she is currently the Senior Public Health Advisor of Outreach and Communications for the FDA's Office of Minority Health and Equity, where she oversees the strategic health, the direction of outreach and communications. And she is currently pursuing her doctorate from Morgan State University. So let's all welcome these three panelists. Thank you for your time and participating in this health inequality panel. And we look forward to learning more about your expertise and learning more about your experiences. So I will go ahead and start with the first question for our panelists. People have stated that the COVID-19 pandemic has publicized or brought to the limelight an issue that has existed for years, which is the disparities that exist within healthcare. What are your thoughts and opinion on this?
So I can start off by talking about this. First, I want to add that thank you for inviting me and an acknowledgement that I too am an Emory alum. So I'm very proud to be here. I am a graduate of the class of 1988 for the undergraduate college, Emory College, and then later a graduate in 1992 for the Emory School of Medicine. So I'm delighted to be here with you all today. And just in relationship to your question, I think as early as end of March, early April, we began to see these reports of inequity for states that were actually reporting race-based data. Many of them weren't, but it was very clear that Black and Latinx and Indigenous people were becoming more ill with COVID and more likely to die, such that Blacks and Latinx patients were dying at 2 times the rate, and Black, Latinx, and Indigenous people were hospitalized at about 5 times the rates of whites. And so the next question, of course, was why? Why is this happening? And then because I was doing a presentation about this, wanted to look back at some of the literature, and there was a study or a conceptual model that was proposed back in 2009 for the H1N1 virus that sort of really resonated even today, where they talked about the difference in social position that is based on race and racism that leads to differences in the quality and amount of education that people have, the jobs that they get or occupations, their income, their wealth, and the like, that can lead to differences in first exposure to the virus. So if, for example, you have a job where you can telework or not, that's different. Also, if you live in an intergenerational home or you have a smaller home, that you're more likely to be exposed to the virus. Also, those determinants or social determinants of health led to differences in susceptibility because there are differences in underlying conditions that are based in part on where you live and other things, other social determinants of health. Also, they suggested that it's related to differences in treatment. So that could, for example, be due to lack of access to insurance, uninsurance, but also, unfortunately, that even when you are able to get access to care or see a physician, that the care that you receive may be different based on your race. And I have been humbled by knowing that we are a part of bias and racism, even in medicine, and that sometimes there's differential treatment that's based on race. But all these things are additive and ultimately lead to unequal illness and ultimately death amongst these different populations.
And yes, I mean, I'll agree with that. First, let me say thank you I'm also an Emory alum, as mentioned, and also worked on Capitol Hill for the former Congressman, Congressman John Lewis. But first, let me tell you a little bit about Black Women's Health Imperative. We're a national nonprofit organization dedicated to advancing health equity and social justice for Black women across the lifespan through policy, advocacy, research, and leadership development. Black Women Health Imperative also identifies the most pressing health issues that affect the 22 million Black women and girls through evidence-based strategies. And so I definitely agree. And just sort of to piggyback on that, we also looked at, for example, some of the inequities which were beyond just some of the underlying causes of some of the severe complications of COVID-19, which were, for example, diabetes, hypertension, obesity. But then we also looked at the social determinants of health and tried to really figure out, how this is an opportunity to sort of create innovative ways to sort of address those health disparities. And so I think many of us in the health policy community, we've known about these health disparities for a while, so it wasn't something new for us. So definitely it did shed light on it. But we do see it as an opportunity with the heightened awareness where we can now come up with solutions that would, sort of address the health disparities issue. And then also early on, many in the Black community, some of the first things we heard was, African Americans cannot get COVID. And so we put together a strategy of about 6 or 7 and quickly pivoted and created like about 8 virtual conversations with Black women organizations across the country, really talking to them about COVID and some of the recommendations. And sometimes the recommendations, for example, when you talk about kids going back to school and kind of getting back into your community, because of the mortality rates and what we're seeing in the Black community, those recommendations, even the recommendations we saw for the mass recommendations, were not necessarily the ones that we saw as ones that if you are, for example, African American and you are, living in a multi-generational home, or sort of even some of the different, if you're a child, sort of living with, also an elderly grandparent, it may not be wise for you to have your child go back to school. But we quickly tried to figure out, to sort of educate the community that yes, you can get COVID. And then two, to also talk to them and provide recommendations on how to sort of protect yourself during this time.
Good evening, everyone. I'm also very happy to be here to join in on the discussion. Just a little bit of background. So I am in the Food and Drug Administration, Office of Minority Health and Health Equity. And as our name implies, a lot of the work that we do stems around addressing health disparities and finding strategies and ways that we can improve health equity. And just to kind of backtrack on what Dr. Jones has previously mentioned when we were talking about the social determinants of health, this isn't new. These health inequities have been around for long standing, and it's not just COVID related, it's also other chronic diseases where we see these disparities like diabetes, heart disease, lupus, sickle cell disease, etc. But one of the things that, we aim to address is really looking at how can we better educate our diverse consumers. And one of the things that we're really focusing on in the educational aspect is language. So for example, if people speak another language other than English, how do we address that? For example, if they are a low literacy population, what tools do we have available to make sure that they're getting the information that they can get? We recognize that not everyone is sitting at home, going to FDA.gov and, searching for the information. So we have to be creative in our strategies and approaches to make sure that we have valuable information where people can make decisions about their health and make informed decisions. As Tammy mentioned, there were a lot of misconceptions, there were a lot of myths around COVID. So it's part of our job to make sure that we are dispelling that information with the hopes of helping to reduce some of those disparities and inequities that we are seeing. Other populations we have to consider are rural populations, for example. Everybody wants to move to, internet-based education, but rural populations just don't have the bandwidth to get on the internet. So again, finding those different strategies of how do we get those materials into the community. So it's really about building partnerships with community-based organizations, those people who are on the ground, faith-based organizations, to make sure that we are providing an avenue where people can get the information that they need so they can become better informed consumers.
And if I could just add one last point, because Giovanni and Tammy both, they have been in this space of public health in ways that those of us who are clinicians have not been. And it's very humbling that we recognize more and more that what we do in clinical medicine is so small by comparison for the entire health of an individual. So even if, as a clinician, I get the diagnosis and the treatment plan exactly right, I recognize that the patient can go out into the world and maybe the medications that I prescribe, they can't afford. Maybe I've recommended that they have a diet, ripe with fruits and vegetables, and they live in a food desert. Perhaps I've recommended that they get exercise, but they don't have neighborhood sidewalks in their neighborhoods, or it's an unsafe environment. And so increasingly, unlike when I was in medical school, where we spent 8 hours a day in the anatomy lab and in the ivory tower reading, that we are transforming medical education. So as a faculty member, that's one of my roles as well, is trying to think about how to get the next generation of physicians to think about health in this broader way, so that we can engage. And policy and advocacy is one of those main features. And so we push our learners now outside of the classroom. It's mandated to engage with community partners about all levels of health. And we believe, because now people can learn the things that we used to spend so much time memorizing on their phone, and they're really smart people, that's, another hour of a lecture in anatomy is not as important as learning learning how to meet people where they are and engage them in problem solving. And so even if they are doing their clinical work, they can actually be better because they will be more patient and understanding when someone's blood pressure is not high, it's not controlled, that they can better engage with them for problem solving and again, meeting them where they are. So I want to thank our public health professionals for helping us to understand that.
I would just add to that. So one of our core stakeholder groups are physicians. So we definitely want to make sure we're using a multi-sector approach when we're doing our work. And one of the things that we really value is getting the input from the physicians, because you all are seeing the patients, right? But sometimes there is a gap there between, you know, the public health and the clinician side. But it's really important for us to say, well, here are the gaps. Here are some areas that you all could address. Here's what I'm hearing from my patients. And then therefore we can take that information and develop content and materials, whether it be fact sheets, brochures, or multimedia videos, etc. So I think having those opportunities to bridge those gaps is really important when we're talking about how do we address health disparities. It's not this sector needs to do this sector needs to do this, but we need to have it everywhere. And we talk about, for example, health in all policies. So it doesn't stop at, you know, just one agency, but looking across the board. So when you going back to those social determinants of health, so what influences health? Education does, transportation does, housing does. So how do you have all of those people together so we can help have policies in place that make it easier for people to make decisions for their health and for the health of their family members?
And I agree with, you know, Giovanni as well. You know, kind of looking at all the different groups, the providers, the patients, the community-based organizations. But then you also get into another piece that, you know, a lot of folks are sort of talking about within the healthcare community. It's about implicit bias. And you know, even if we control for all of these things, if your physician, for example, used to sickle cell as an example, even if you control for all those different things, but if the patient comes in and say, for example, if you're a sickle cell patient and your pain isn't taken as seriously, or you're seen as more of a drug seeker, or for example, we look at maternal mortality where Black women are 3 to 4 more times likely to die in childbirth. You know, how do we, regardless of education level, income, so even after we control for a lot of those things, there's still, many will say, there's still an inherent sort of structural racism in the system. And then in terms of providers, there's studies that say that Black patients do better with Black providers. So in order to get more of those physicians in the pipeline, I mean, Dr. Jones, you're probably better well suited to, you know, definitely talk to this, is we do have to increase the number of minority physicians in the pipeline. So it's definitely a multifaceted approach to sort of addressing health inequities.
So Tammy, to your point about the implicit bias, one of the things that I've been able to do in my office is implement staff-wide training that addresses implicit bias as it relates to health education, promotion, and communication. So I'm a strong believer of education to start at home. So you need to have your staff trained up and ready to go to be able to address these issues. And another training we implemented was around cultural competency. So how do you take in all those cultural nuances when you are trying to communicate and engage with a specific community? So having those trainings, I think, is very important to, you know, raise awareness, hopefully affect behavioral change. We know just because you give someone information doesn't mean they're going to change their behavior, but, you know, having those opportunities to having those open and honest discussions to figure out where are the pain points and where can we, you know, move the needle forward, I think is very important too.
I'm really glad you guys are segueing into kind of this provider bias and how that intertwines with health inequities. But, you know, fear of contracting COVID-19 has prevented some patients of color from seeking hospital care for things like heart attacks and strokes. How could safety concerns among Black, Indigenous, and people of color communities, those communities, worsen existing racial inequities in healthcare access?
I'm sorry, I'm not sure if you're talking about safety concerns. I was thinking about the bias part of it and how that may play into how people seek care. But I also think that, as you're suggesting, their concerns about safety, not specific to any race or anything like that, may also impact their ability or their desire to seek care. We are certainly seeing people with a reticence to come to a healthcare system, to leave their homes, and that has had a significant impact. But I also want to acknowledge that this issue around provider bias is one that has been increasingly salient. It's one where physicians, there's a study done by Kaiser Family Foundation that showed that most physicians didn't even know, this was just a few years ago, didn't even know that disparities or inequities exist. Let alone that we could be in any way sort of implicated in that. And to me, it's very similar and similarly unfortunate as when we think about policing, for example, in the sense that everyone has biases. Everyone on this meeting, whether we are Black or brown or what have you, have our own biases. But in the case of policing, in the case of providing healthcare, where literally life or death decisions are on the line, that the decisions that we make and the biases that we have can result in life or death decisions. So as was mentioned, we are increasingly talking about this in our medical school. Almost every school is having sessions about this. We're also looking at, driven by our students themselves, about how we talk about race. I saw in the chat a question about the biologic versus other. We know that race is a structural, a social construct, and that it has nothing to do with our genetics. And so when even the way we train, we do cases, for example, and we take our board examinations and MCAT examinations, and they say a Black patient with X, Y, and Z, or we're on our clinical spaces and we refer to someone's race. What does that mean? Why is that important? Why are we even talking about it? So being more explicit and intentional about how we talk about race, but also talking specifically about the implications of our own biases and calling each other out, beginning to look at our data so that we can make those changes.
Great, thank you guys so much. I'm gonna ask another third question. So in terms of, we're talking lately in the community and in society about COVID and the COVID-19 vaccine. So my question is, how can we ensure that the future COVID-19 vaccine or vaccines are distributed to those populations that are affected the most by health disparities?
Go ahead.
Oh, so yes, I mean, so one of the things, as you know, the National Academy came out with its recommendations. Like with health imperative, we also submitted comments. Like once you vaccines out, how do you actually allocate that vaccine is one, sort of one issue. But then secondly, specifically to your question, is how do we actually get, the community or folks to take the vaccine. And so I think in the African-American community, there's definitely an approach, it's not just as simple as the vaccine's ready, let's give out, everyone come in and, can get that vaccine. And so there are definitely several conversations that are starting to happen. I know that all four of the HBCU medical schools, Morehouse, Meharry, Howard, and Charles Drew are definitely involved in the COVID-19 vaccine. And then also there's Meharry's president is also on the FDA advisory piece, but then also there are conversations going around, and across the country where conversations are happening. How do we address, we address the trust factor. So you have to sort of get over there's a historical basis to why African Americans may not take the vaccine or be the first ones to take the vaccine, although they are one of the very high risk groups or who have severe complications and mortality rates from COVID-19. But it's key for us to get them into the COVID the vaccine clinical trials, because and Dr. Jones can speak to this, because it's very key to see even how the drugs may even interact with their conditions that they have as well. But you do have to address the trust factor and who that comes from. It has to be a trusted messenger. B, once you have the vaccine clinical trials, you want to even talk about, like, what does informed consent look like? Are you actually telling the patient everything that, you know, they may experience by participating in this? And so I think it's just not as simple as, hey, we have a vaccine now. You have to also get into other nuances in order for, I want to say, one of the more, you know, the more high risk populations to actually take the vaccine.
Yeah, and I think when we think about trust, which is one of the main barriers that people often talk about when they're talking about Blacks and Brown participation in research, that we have to acknowledge first that there is a reason why there is mistrust, right? There's been years of experimentation. So you could start back at hysterectomy surgeries that were done without anesthesia. They were perfected. Dr. Sims, you know, did those studies that we use many of those things even today. People think about the Tuskegee experiment, where people were not treated for syphilis even when a treatment was available, so they could follow amongst Black men the natural history of the disease. Or Henrietta Lacks, whose genetic and biologic materials were used for astounding discoveries over the years. But oftentimes it's just everyday racism that spills over into their interactions with physicians, with researchers. And so people react with mistrust, understandably. And so my thoughts are that we have to work to gain trust, to earn trust as clinicians and as researchers. I think there is emerging evidence about how Black providers may be less biased, but in general, we have our biases too. There's much more evidence that suggests that race concordant relationships, that patients prefer race concordant relationships, that in the clinical environment, they're more likely to come back for their appointments, they're more likely to have better outcomes, to take their medications, all those things. In research, if the researcher, the PI, or the principal investigator is of the same race or is Black specifically, then you will get more minority participation. So that's number one. I think so. Increasing the pipeline of Black and Brown scientists is one of the things that we need to do. I think this issue around community engagement is really important. That's why we're pushing our learners out in the community, and not community engagement that's just tied to one trial. So like, you're gonna do this experiment for a year, you got a grant funding, and then see you later. But what we're trying to do in Emory's COVID response now is have a more sustained engagement with the community, where we not only engage them before the trial, but also tell them the results once they happen, and really have
Just
more
for a little bit.
have more
A webinar.
Because most people, when they come and work with communities, they tend to think, I know what this community needs, I know what your problem is. And the really researchers are increasingly thinking about more of an asset model approach, where you understand the strengths of the community and try to build on that. And so, and the bottom line, my last point I would say, is just listen, engaging more community advisory boards, community stakeholders, and really engaging them in the research process, asking and answering their own questions as well.
So I would say that diversifying clinical trials is critically important to making sure that we have safe and effective medical products for everyone. We do know that sometimes, you know, based on your race or ethnicity, you may respond differently to a medical product. So if we don't have the people who are going to ultimately use the end product, then we have no idea how they're going to react. So we don't have a complete data set. So it's very important that we work hard to get a diverse group of people enrolled in clinical trials. And to the points that have already been made, is, you know, critically important to build that trust within the community. Actually, one of my flagship programs is our Diversity in Clinical Trials initiative, where we are aiming to raise awareness around the importance of diversity in clinical trials. And part of what we do with our campaign materials to make sure that they're authentic and credible is actually use spokespersons who represent those community. So we're not just hiring actors who, you know, we give them a script and say, here you go, but we're actually having people from the community, and we're working with them in tandem to build the scripts, build out the videos, and making sure that they believe in the messaging and they're helping to amplify our agency's messages. Another thing that we do as an agency is we put forth guidance documents for industry. So industry are the folks who are conducting the clinical trials, for example. So we have guidances on how do you diversify clinical trials. So whether that be, you know, back to the community engagement piece. You can't be this helicopter researcher where you come in, get what you need, and you leave the community. You have to build that rapport with them so they feel valued and they feel a part of, the research process, and they don't feel taken advantage of, because there have been tons of historical abuses for race and ethnic minority communities. So to overcome that, you have to definitely, build the trust within the community and really look to those gatekeepers. So, who are those advocates? Who are the champions in the community? And how do you tap into them to help bridge, those relationships?
Great, thank you guys for your responses. I think at this time we're going to separate everyone into their breakout rooms respectively, and then we'll come back at the end and regroup. So at this time you'll be automatically allocated into a breakout room. So if you could just stand by.
What happened?
Let's see. All the breakout rooms are closing in about 40 seconds. So I think they're probably all just wrapping up their sessions before returning back here.
All right, I think we're all back. All back? Great. So I wanted to thank everyone for participating in those breakout sessions. I know in my room with Tammy, we talked about the importance of patient stories, building coalitions, making sure that you're calling your member of Congress, your elected officials at the state and local levels, because without sharing those stories and advocating on those issues, they're not going to know, and having them know is the best way to get legislation to move forward on your particular issue that you're advocating on. So I wanted to pose a final kind of wrap-up question to everyone, and Tammy, we'd like to start with you. What's one key takeaway message that you want to leave our attendees with? How can we as Rollins alumni advocate for legislative changes?
Yes, so I would say, developing, what your ideas or your legislative or your recommendation to Congress, would be great. For example, if we had a group of Emory, alum, Rollins School of Public Health alum, and together we sort of pushed a particular issue, a legislative issue, and meet with our members of Congress. I think the doors are definitely always open, but really developing a network and a coalition to sort of push those issues and coming up with specific recommendations, particularly around health equity and COVID.
So I'll just add to that. I agree completely with Tammy. I think the first place where I start, whether I'm doing community-based advocacy, which is what I'm more passionate about, or advocacy within my own system, trying to change things the way they are, that it's starting with a problem that keeps me up at night, like something that I'm really passionate about, and then whether it's engaging with others for grassroots kind of organizing, increasing my own skills, like by reading more or getting informed. I have participated in op-eds, don't do as much social media, but that's another possibility, or writing blogs. But I really think that advocacy takes place at multiple levels. So whether you're doing it in a legislative space or your own organization, making changes, policies and practices that can all lead to more health equity, I think that those are really important ways to begin.
So I would just add that, everyone should take an opportunity to reflect on how do health disparities arise, where are these health inequities stemming from, and make sure that you just take the time to educate yourself about the issues. Attending forums like the one tonight, talking to different colleagues, reading a book, taking a training, all those types of things, and really, starting to think outside of the box. So how can your organization either lead or support these types of efforts? I think is also very critical, because we need to make sure the space that, we are existing in is, as best of a space as possible. And really taking on, that role would be very helpful in making those organizational changes.
Well, thank you so much to our distinguished panel. I thought this was very helpful in kind of, talking about health inequities and really kind of trying to figure out, well, how can we, translate that into some positive change. And so I'd like to, again, thank you, Tammy and Giovanni and Dr. Bussey-Jones for joining us tonight and sharing your expertise with us for a little bit. At this time, I'd like to go ahead and turn it back over to Laura and Steve.
They all got PhDs though?
Well, thank you, Christopher. I'll just wrap it up here. I know we're nearing the top of the hour. Many folks have shared that they want to stay in touch and keep the conversation going. So I'll let you know that we'll be sending out a follow-up from this meeting with folks included, so you can connect offline via LinkedIn or other social media channels. Just a few quick reminders here or notes. First of all, this is one of many sessions that both the Emory Alumni Association and Rollins are putting on during this time. So emorycollective.com is a great way to see all of the opportunities across the university, as well as recordings from previous programs, articles, news, and updates, and more. I would be remiss for the alumni here. Homecoming is coming up next weekend. It is free registration, a number of events across all schools and units. So I'd encourage you to check it out. You can join from your couch, your bed, your deck, wherever you might find yourself in your athleisure, but we hope you take part in that. And again, it is free. It's homecoming.emory.edu. A couple quick events that I do want to mention. First is, as we're focused on talking about advocacy at different levels, the Alumni Association, along with Government Affairs at Emory, will be doing an advocacy series starting in January. It'll be a 3-part series focused on local, state, and federal advocacy efforts, bringing in experts from across the university to help educate our alumni community on how to be strong advocates wherever they find themselves. So hopefully that is a great continuation of this conversation come January. We do have 2 election events coming up. While we can't escape it, it is election time, and we'd be remiss if we didn't encourage everyone, if you have not already, to find your polling place, where to vote, whether it's mail-in or in person, to have your voice heard. But we do want to note, first, next week, the DC Network will be hosting a political law discussion with 2 Emory Law graduates talking about the current state of the election. That'll be on the 21st. Then we'll have Alan Abramowitz joining us for a last-minute election analysis prior to Election Day, and Andra Gillespie will be joining us on November 5th for immediate reactions to Election Day and what those results are. And then finally, the Barclay Forum is actually hosting post-debate analysis with members of the Barclay Forum and key alumni experts. So if you're looking for political experts and commentary during this time, we hope that you'll join those Emory experts. But I'd like to see, Laura, do you have any closing remarks as well on behalf of Rollins?
Hi, everyone. I'm Laura Juritich. I'm the Assistant Director of Alumni Engagement and Annual Giving at the Rollins School of Public Health. Thank you all so much for joining tonight for such a fantastic event. If you are interested in getting involved with Rollins DC, we have a fantastic group. We have about 600, 700 Rollins alumni in the DC area. We have great programming led by Christopher and Elisa and a whole great team. So we would love to have you involved. You can just shoot me an email, or you can find us on LinkedIn or Facebook. We are going to have a couple events during homecoming. Like Steve mentioned, we're going to have one about does your zip code determine how healthy you are? So that would be a great one for everyone who attended tonight's discussion. And we're going to have a couple others in partnership with other schools and units. So I think it'll be exciting. And we're going to do a little Rollins DC chat after that zip codes one. So hope to see you all there.
Well, thank you, everybody. And thank you for participating. If you look for a recording, it'll be on Emory Collective next week. And we thank you all for your time tonight and look forward to seeing you in another virtual event soon.
Thank you, everyone.
Thank you, everyone, for joining and your time. Thank you. Have a good evening.